So now we record the lecture, and now I will give the full screen. So please let me know. Do you see now the slices?
Yes, perfect.
Okay, so everything is perfect. We can start.
Yeah, very well.
Okay. So today we will discuss about the neuroradiology, and I will show you these men which are really one of the pioneers in our discipline. You recognize Röntgen, which is the who discovered the X-rays, and after that the big implementation of our discipline of medical imaging is due to Hounsfield, who the man who take the Nobel Prize in 1979 for the discovery of the Hounsfield units, and after that one of the foundators of the MRI, Walter Burr. Okay, so again, as any other system in the assessment of the central nervous system, we are usually using the conventional radiography, but the most important role nowadays is contributed by the CT and the MRI. Of course, invasive or interventional angiography procedures are very important in some occasions for treatment, especially of some brain anomalies or aneurysm, and ultrasound has a limited role. So we will start to discuss each of these imaging modalities. So starting with the conventional radiography of the skull, you can see here in frontal projection the anatomical structures and what do we see on the conventional X-ray. If we are dealing with a patient with trauma, sometimes it's necessary to make not only the frontal projection, but to perform also a lateral projection. So in lateral projections, you can see clearly the skull base, the sutures, and also the first cervical vertebra. So what can be assessed and what are the indications for performing the conventional radiography? Okay, so now we observe frontal and lateral projection of the skull. In this patient, we see something calcified in the left part of the brain, and it's displacing a little bit the skull, the bones. So what could be this? Of course, we are not able to do it to give the final diagnosis only by conventional X-ray. We will need further evaluation with CT or with MRI, but here we can say that it's some calcified structure which is very well delineated, and just from the basic conventional radiography we can say probably in differential diagnosis it could be a calcified meningioma, but of course we need further evaluation. When we have something like that, we always continue with CT or MRI. Sometimes the changes are very, very subtle, so we should look for fractures mainly. These are the frontal sinuses. Those are the maxillary sinuses. We see some fluid level here, probably, maybe, or either hypertrophy of the mucosa of the right maxillary sinus, because here it's fluid there, which is normal. The same density like the orbits and like the frontal sinuses. But if we take a closer look here to the left lateral wall of the orbita, probably it's a little bit, we are not clearly, we don't see the contour delineation. Probably it could be some traumatic changes on the lateral wall of the orbit. So of course, in this case, again, we will need to perform later after this radiogram a CT. So CT is indicated for trauma and also for intracranial hemorrhage. This is a severe trauma. What do we observe? So air inside of the falx cerebri or in the skull. So a big lesion here with air inside of the skull. And this is the lateral projections. Again, we see here some irregular shaped translucency, which can be due to trauma. This could be also impaction of the sutures sometimes, or not the sutures, I'm sorry, but from the vessels. Those are the vessels. But if we take a look here, what is this? This is an enormous, like a big hole here in the occipital part of the skull, and we're not pretty sure. It could be either a tumor or traumatic changes. But if it's a traumatic change, we need again a CT, because It could be a gunshot trauma as well, because we can observe here the projectile, the line of the projectile. Probably it could be also a gunshot. I don't know exactly, because those are just some examples to say you that if you don't have some medical history for the patient, you don't know what you are observing exactly. You are very limited with conventional X-ray. You are limited only to some traumatic changes, not more. But you always need to perform further on CT or even MRI to give the final diagnosis.
Professor,
Yeah.
just when you explain something, could you please show us with the cursor to see?
I'm showing, but if I'm using the full screen, you don't see the cursor.
Okay.
If I exit from the full screen, you will be able to see the cursor, but the image will be.
No, it's better like this.
It's better to stay like that. Okay.
Yeah.
I will try to explain you. Okay, thank you for this suggestion. This I will try to explain you, because I'm showing you right now. I'm showing with the mouse, but you don't see it.
Yeah, I understood. Yeah, the problem is in your...
Anyway, yeah, I'm sorry here. There are a few slides. I didn't have any time to translate them into English, but I will give you the explanation. It's just to familiarize you with what are the main imaging CT characteristics on CT images, and what are the main anatomical structures in the brain. So when we perform CT of the brain, we can delineate the white matter and the gray matter. The gray matter is at the periphery, and the white matter is in the middle portion. We have the cerebrospinal fluid, which is with hypodense. It's a hypodense structure. But what is inside of the lateral horn of the ventricles? What is these hyperdense structures? Obviously, those are some calcifications, because if you measure the density, here is the same density like the bone. So it's bright, very, very bright, or hyperdense. So those are normal findings, and those hyperdense structures or calcifications in the occipital horns of both the lateral ventricles, they represent calcification in plexus choroideus, in the choroid plexus. So this is a quite normal finding. Even in the third ventricle, here in the middle, between the two calcifications, you can observe the same image. So it will be described as a calcification in the third ventricle gland. So on other slides, which at different levels, you can observe the normal CT anatomy. And of course, you see the orbiter here in the first image. Then a little bit at lower projection, you can see the brainstem. Those are the orbital nerves. The sphenoid bones here at the first row. On the second row, you have the supratentorial brain, the main cerebral hemispheres. In the middle lower image, at the middle, in the lower row, you can see the basal ganglia running on both sides of the lateral ventricles. Again, a slight calcification. You see it here, you see it on the previous image. On the left side, the calcification in the third ventricle, which is a quite normal finding in patients after the age of 30s or 40 years old. So evaluated anatomically with MRI. And MRI can give you not only axial images, but also sagittal, like in this case here, and coronal images. And we should be able to identify every single structure here, because if we have some pathological entity or some process, we should describe the location. And after the location, this location, especially in the brain, is very important, not only for the neurosurgeon, but also for the neurologist, because every center is reflecting some motor or some could have some other motor or sensory deficit, for example. So you can see in the middle here, this linear or angulated structure, which is number 4, is the corpus callosum. You can see the brainstem, 17 and 16. 17 is the pons, and 16 is the pons, and 17 is the mesencephalon. Then 14 here is the medulla, the myelon. Okay, so it's important to know the anatomy. What is the main difference you know already between T1 and T2? In T2, the first image on the left side of your screen, the cerebrospinal fluid is dark, hypodense. And in T2 images, the cerebrospinal fluid is white. And also in T1 images, it is correct that we have the white matter, which is with hyperdense, and the gray matter a little bit hypodense. So gray matter is gray and white matter is white. And here it's the opposite. In T2 imaging, the gray matter is brighter than the white matter. So it's a little bit opposite. You should differentiate between T2 and T1. In T2, the liquids are bright. In T1, the liquids, the cerebrospinal fluid is dark. In both T1 and T2, the fat tissue, the lipids are superficial fat, are bright, hyper intense. Okay, and now you will see few slices with the anatomic wrappers or the anatomic levels, different levels with the structures, just to familiarize you with the normal anatomy. Okay, so we start from the top of the brain, and we are running to the level of the left of the both lateral ventricles. You see them clearly here on the left image with the bright signal intensity, so they appear as hyper intense because this is a T2 sequence. Then you see here, for example, the occipital horns of the lateral ventricles. You see the frontal horns, the basal ganglia here in the middle. They are very important. Putamen, capsule internal anterior horn, internal capsule globus pallidus. Those are the basal ganglia, and also the thalamus, both thalami here on the left image. And then we are moving to the brainstem, to the level of the brainstem. You see the crus cerebri of the pons. Here is the pons, the cerebellar peduncles. Here, those at that level, we are already at the temporal lobe. We are running from frontal and parietal to temporal and also to occipital lobes. And here we are at the level of the cerebral hemispheres, the both cerebral peduncles and the cerebral hemispheres. Okay, so another level, just to see a little bit anatomy. So how is the intracranial vascular supply? How does it run? So you know probably the Circulus arteriosus cerebri. So this is the connection between the anterior and medial cerebral artery with the posterior cerebral artery. You see schematically here at the level of the pituitary gland, the chiasm, and those A1 is the A1 segment of the anterior cerebral artery, and M1 is the first portion of the proximal segment of the middle cerebral artery. And in fact, this is the so-called circle of Willis. So in the circle of Willis, we have a connection between the anterior vascular supply of the brain and the posterior vascular supply of the brain. So the connection is performed via this posterior communicating artery, which relies the middle cerebral artery and the internal carotid artery with the posterior cerebral arteries, or the basilar. This is the basilar artery. So this circle of Willis is very important because if we have unilateral obstruction at one level, we will have a blood supply from the contralateral part of the brain. So if we go back to the conventional images, you can see at that level here one skull fracture on the right side in the frontal and parietal bone, but it's very, we obtain much better image quality and much better information from the bone windows with reconstructions during CT evaluation. So those are the normal sutura. The suture. This is the occipital suture or sutura, and they are normal. But if we have some fracture, so what is the type of pathology here that we observe. We observe sub-impaction fracture with a huge, massive hematoma. Not only subcutaneous, but also you can see the depression of the bones. They appear depressed. The right frontal lobe is frontal bone is depressed, and we have this important hematoma at the level of the fracture. And what is the pathology on the other image at the base of the skull? If you take a closer look on the left side, where is the mastoid cells, mastoid bone on the left side, close to the left ear, you see a linear structure which is running parallel to the pontocerebral angle. And this linear structure is once again a fracture line. So those depressed or fractures or impaction fractures, they look like that. For example, if you're if you're taking some, giving some, I'll say some injuries to a person with a hammer, for example, you will observe this kind of depressed impaction fractures here, which could be either one with one fragment or with multiple fragments, because in this example here, the next case, you see a multiple fragments fracture with displacement of the bone fragments. So if you're looking on the bone window here on the right side, you can identify and differentiate between the tabula interna and the tabula externa and the diplois in the middle. So tabula externa is the outer part of the skull, the tabula interna in the inner part, and between them, this translucency is the diploid. And of course, again, one hematoma here close to the fracture. So the fractures in the face, in the region of the face and the skull, are classified by the so-called Le Fort fracture, Le Fort classification. You can check it on the internet. The different types of the Le Fort fractures. One is Le Fort 1, which affects only the maxilla. Le Fort 1, Le Fort 2 affects the maxilla and the middle part of the orbita, and Le Fort 3 is the lateral part of the orbita and also affecting the zygomatic bone. So this is Le Fort 1 fracture. And here another more complicated Le Fort 2 fracture, because in Le Fort 2 you have on the second image on the right side, so I'm sorry here about right and left side. For me, it's the bigger skull is the first Le Fort 1, and the smaller image of the skull, which is not so zoomed, not so magnified, it's Le Fort 2, because you see in Le Fort 2 the lower part of the left orbita, but also the lower part of the right orbita, a fracture. On the left side, it's a little bit displaced, this fracture, so it needs to be operated. So we are passing to the meninges. Meninges are arachnoids, dura mater, and pia mater, which are just below the bones. This is the bone here, and the three types of meninges. And then you have the periost and the skin. Inside of the brain, we can observe different types of cystic lesions. When a patient has been operated, we can have an image of some kind of, not only after traumatism, but also after a big part, after some ischemic infarction. The cystic lesion in the middle image here is affecting the posterior fossa, and it's an image of a megacisterna magna. And on the left side, we have a huge hydrocephalus. In hydrocephalus, we have abnormal dilatation of the lateral ventricles, and in the same time we have a little bit atrophy of the parenchyma because of the compression of the surrounding parenchyma. So if we are speaking here about the different types of hematoma, we should be able to differentiate on CT between epidural or so-called extradural and epidural and subdural hematoma. So this is a typical example of epidural hematoma, which is fact accumulation of blood between the dura and the cerebral bones. We have a high evaluation of the pressure, intracranial pressure, with compression of the surrounding parenchyma. And usually it's the location is transtentorial or with herniation in the level of the uncus. And we have that so-called triad of Cushing with hypertension, bradycardia, and difficulties of breathing. So just please remember this typical concave convex visualization of the hematoma. So this is another example of epidural hematoma here with some blunt trauma in the first axial image here. The hematoma is also intraparenchymal, and there is an important complication because the blood inside the white structure, the hyperdense structure is the blood, is entering the lateral ventricle, the left lateral ventricle, which is importantly displaced to the left side, to the right side. And when we have blood inside of the ventricle, it should be treated by surgery. This situation is really a very important one. The other type of hematoma is called subdural hematoma. And subdural hematoma have the typical appearance from one pole, from the frontal pole running to the posterior pole. So the shape of the hematoma is completely different. It's like the so-called croissant appearance. And so the blood is accumulated between the dura mater and the exterior meningeal fascia. And again, we have increased intracranial pressure, which can lead to some damage of the brain tissue, the surrounding brain tissue. And those subdural hematoma usually are acute after trauma, or they're chronic, and the chronic hematomas can develop in a few days or even few weeks. And we observe them, for example, in adults which are treated with anticoagulants. And the treatment of those hematomas is usually surgical decompression. So another examples of subdural hematomas on CT at different levels of the brain and in different stages. So if at the last image, when we see bilateral hypodense areas between the bones and the brain tissue, those are called hygromas. Hygromas is already, this hematoma is transformed in liquid. But once we have hygroma, which is a sign of old process, a chronic stage, we have here another epidural hematoma, which is a new entity in this patient. And the third type of hemorrhage is after subdural epidural hematoma is the subarachnoid hemorrhage, which in fact is presence of bleeding into the subarachnoid space, which is located between the arachnoidea and the pia mater. And usually we observe it spontaneously after rupture of cerebral aneurysm, if we have a patient with arterial venous malformation, or after some skull trauma or brain trauma. And the symptoms can be headache, dizziness, agitations, even meningeal, some, I don't know, some different types of symptoms can be observed here, but they get lost. The patients, they are a little bit lost. So different examples of subarachnoid hemorrhage. You should look here for the hyperdense areas in the subarachnoid spaces, which usually are filled with liquid or with cerebrospinal fluid, but here they are filled with blood. And if you observe something white or hyperdense in the image, every hyperdense structure here on the 4 images is due to subarachnoid hemorrhage. So the diagnosis of those hemorrhages is 100% sure with CT. The sensitivity is very, very high, up to 100%. And MRI is a little bit more precise compared to the CT in the late stages. Sometimes you can use angiography and even a lumbar puncture, because 3% of the cases with negative imaging diagnosis from CT or MRI can be diagnosed with lumbar puncture. So we will observe some blood into the cerebrospinal fluid. Okay, so now we will speak a little bit ischemic stroke. How can we differentiate or characterize the different types of stroke, ischemic and hemorrhagic stroke, with which imaging methods we should rely on, and what give us what answers can give us the radiology or the medical imaging in that? How can we treat the insulations or the ischemic strokes? We should know that when we have a loss of some kind of brain functions due to inappropriate vascular supply, it could be 80% due to ischemia, due to thrombosis or embolism, and 20% of hemorrhage. And usually it's either intraparenchymal or subarachnoid hemorrhage. So of course, for those situations, because the CT is the gold standard in cases of hemorrhagic stroke. So if we are dealing with hemorrhage, we should go for CT. 60% from brain ischemia is visualized from 6 hours after the onset, and up to 85% can be diagnosed in the first 24 hours after the onset of the situation of the disease. So with the sensitivity, it's up to 65%, and the specificity of CT is up to 85%. So if we are supposing a hemorrhage, you better run for CT and not for MRI. And the early signs of the ischemic stroke, what are they? So sometimes we can observe some hypodense areas. You take a look at the upper image. On the right side, it's a little bit slightly hypodense comparing to the left side when you have this yellow arrow. And this is probably a hypodense area which is irreversible brain damage. And this is due to occlusion, which sometimes at the lower image here, you see a high arteria, middle cerebral arteria. So the so-called MCA sign means high density in the cerebral artery, in the middle cerebral artery, and you can visualize it up to 90 minutes after the onset of this ischemic stroke. Sometimes in ischemic stroke, you will not be, the differentiation between the white matter and the gray matter is not so clear. You can see again the upper image here on the differentiate very well between the gray matter and the white matter comparing to the non-affected left side. A few examples of ischemic stroke on CT. The first image is the ischemic zone is located in the parietal and temporal lobe on the left side. We see a mass edema. This mass edema is causing compression and even loss of contours of the left lateral ventricle. On the second image, you see the bright MCA sign, so the hyperdensity in the left middle cerebral artery, which is due to thrombosis in this artery. Then on the third image, you have affection in the occipital lobe on the left side, and the lower lobe, you have the very last image here. The sixth image, you have hypodense area, which is more or less with equal density like the cerebrospinal fluid, because it's a very chronic stage. It's an old process and it's completely liquefied. So it will turn to arachnoid cysts one day, for example. On MRI, the ischemic stroke can be visualized with T2 sequences which will present bright signal, hyperintense signals, and T1 sequences or flare sequences, it will be with low signal intensity. Hemorrhagic stroke, again, intraparenchymal hemorrhage, and probably 50% of all MCA infarctions are hemorrhagic. They could be diagnosed either with CT or with gradient echo MRI sequences. And when we have a hemorrhage, we should tell the neurosurgeons from which vessel, which is the territory of which vessel is affected. So for that reason, we should perform CT perfusion, and with this method, we can assess the tissue in risk. If we perform it in the very first minutes after the onset of this clinical condition, we will be able to differentiate between the area at risk and the irreversibly damaged parenchyma. So on MRI, the stroke, again, it's located here in that image on the left side, affecting the parietal and temporal part of the temporal lobe, or mainly the parietal lobe. So we can prove the ischemic affection in till the second hour after the incident, and we will use PD sequences, T2 sequences, and also flare sequences. So if we have hyperintensity at that level, these hyperintense zones are definitive changes. They will not turn into normal. They are completely ischemic lesions and areas. So MRI diffusion sequences can give us an idea about the damaged tissue, but could not assess the tissue in risk. So only the definitive changes, those areas from the brain parenchyma which are definitely affected, appears very, very bright on diffusion sequences. And this is the most sensitive method for ischemic stroke, the diffusion sequences. So if we have a patient suspicion with ischemic, brain ischemia, we should use this diffusion sequence because they're really very sensitive and they present the damaged areas with high signal intensity. Once again, another example on the left side, you can see that the CT does not give us any answer. It looks like normal. If the first image here is a CT on both sides, the right side and the left side, there is no difference. But if you perform diffusion weighted imaging, even on the early phase, in the very beginning of the symptoms, you will observe this hyper intense area, which is in fact affected by the process, by the ischemic stroke. And also MRI perfusion is a very modern technique from the last few years. And with this perfusion sequence, you inject, it could be compared with the perfusion sequences, and we inject both gadolinium, contrast material, gadolinium, and we can observe the abnormal perfusion, which is indicative for the dead tissue or the tissue at risk. And sometimes we can combine both techniques. Let's say those are advanced techniques, not conventional MRI, but advanced techniques, diffusion and perfusions, in order to better estimate the area which is affected. So you see here on that image on the right side, you have the affected region here right in the red, and the tissue at risk surrounding the red area, the definitive changes, and the normal perfusion on the left side. So these curves here are different for the left side than the right side. They in fact correspond to some infarction on the right side of the brain. Okay, a few words about the invasive or interventional imaging methods or procedures for diagnosing a cerebral infarction. So apart with these modern advanced MRI imaging techniques, we can rely on the gold standard, or this is the DCA, or digital subtraction angiography. So with angiography, we can, for example, rule out thrombosis of the middle cerebral artery. Like in this case here on the left side, you have one thrombosis of this artery, thrombotic part. Sometimes this thrombosis can be complete, or sometimes you can assess some stenosis. Like for example, at that level, you have a stenotic part of the artery, very short segment, and something like a defect inside of the vessel. I don't know, it's a gas bubble or some thrombus, microthrombi, or some small clot here with the arrowhead. And with angiography, you can even have an idea about extravasation of contrast media in some, either in complications or in some cases of rupture of some intracranial vessels. So this is extravasation of the contrast. So you have a normal vascular opacifications of the intracranial brain cerebral arteries on the right side, but you have this big contrast, fluid contrast structure in the middle of the brain, which is in fact the extravasation. So the aneuvrisms are, as we thought already, they are, if you have a patient with aneurysm, you have a big risk for rupture. So after embolization of the aneurysm, the blood supply can be stopped, and you will have a normal aspect, a normal image of the vessel. So we treat this aneurysm nowadays with interventional techniques and with embolization with coils. So we put some microcoils or microspirals inside of the aneurysm. If they have a nice neck, the aneurysm should have a nice neck. And when we fill it with coils, we stop the blood supply inside. A part of the aneurysm, we can observe also another vascular lesions in the brain. Those are the arterial venous malformations. In fact, what they represent the tangle of abnormal blood vessels. So a mixture of, you have the schematic image here in the left lower corner of the slide. So this is a tangle of abnormal blood vessels which connects the arteries and the veins into the brain. Usually those arterial venous malformations, they're asymptomatic. They are congenital in more cases, but they're rare, and they're less than 1% of the population. These malformations can develop everywhere in the body, but occurs most often into the brain and into the spine, and that's why we need modern imaging techniques, and mainly MRI with MRI angiography to rule out these conditions. But not only MRI, of course, we can go with CT for them, because the CT with contrast will give a very good image of the blood supply of the aneurysm and also the venous drainage. So the diagnosis on non-contrast CT here, the first image, is not so easy because you don't see the nidus. The nidus is really a little bit higher density comparing to the surrounding brain, but you can observe, however, some enlarged draining veins can be seen, and although they might be very large in size, but they do not cause any mass effect unless they start to bleed. And after contrast administration, on the lower images, you can see better the feeding arteries and the draining veins. It looks like a bag of worms appearance. This is the so-called bag of worms, the nidus. And the exact anatomy of the feeding vessels and the draining veins, sometimes it's very difficult to be delineated, and sometimes it necessitates a conventional angiography, because also with angiography we can embolize these vessels. But why MRI is better? Because MRI gives us better tissue resolution, and you can observe the nidus much easily. So here is the nidus in the axial MRI T2 image. It's seen as a big needles with loss of signal on causing a little bit of mass effect, because we can see compression of the left of the right lateral ventricle. And sometimes the complications that usually are seen from those arteriovenous malformations are usually hemorrhage and adjacent edema. It could be visualized in some occasions. And MRI angiography, we use phase contrast MRI angiography. It's often useful for subtracting the hematoma components when we have arteriovenous malformation, which is complicated by acute hemorrhage. And when we observe when we are suggesting hemorrhage, we should make imaging with MRI angiography. Conventional angiography, or DCA, digital subtraction angiography, still remains the gold standard, and it can delineate the location and also the number. We can count the feeding arteries and the pattern of drainage, and that's why angiography is performed in the B-plane system with a high rate of acquisition, as shunting can be really very, very rapid. So once you inject the contrast, you will see the feeding artery and also very fast shunting from the dilated veins. So we can see this appearance of a packed mass of enlarged feeding arteries and blood inside of them, one or more dilated veins, which drains the nidus, and with abnormal pacification in the veins into the arterial interior phase, which in fact represents the shunting. Okay, so this was till now about the ischemic and hemorrhagic stroke, and now we will speak a little bit about brain tumors, which is probably the most interesting part probably for you in this presentation. So brain tumors, of course, the role of imaging is crucial and so important. So we should, with MRI imaging, especially with MRI, we should put the diagnosis and tell if there is a tumor or not, and if we find the tumor, what kind of tumor it is. So we are not able to give histopathology in every case, but we will try to do it, and also to give some grading of the tumors. Also, we should plan the treatment. So is there any surgical planning, or the patient is appropriate for radiation therapy planning? And also with the MRI, we can assess the post-treatment follow-up of the patient. So we can observe about any residual or recurrent tumor, pseudo-progression, pseudo-response, and the effects of the radiation therapy. So I like very much this statement from the American Journal of Neuroradiology. And the author to treat patients with brain tumors without the use of neuroimaging is impossible to imagine. So that's why we needed really this MRI imaging with modern, not only conventional, but also advanced techniques. So this slide is giving you how can we image the patients with a brain tumor. So again, the slides at the very beginning with white are listed the conventional techniques, and with red are listed the most modern advanced techniques. So as you know already, the advanced techniques, they are diffusion weighted imaging. This susceptibility weighted imaging, SVI, is giving an idea about is there any bleeding from the tumor or not. The perfusion weighted imaging, and single voxel or multivoxels MR spectroscopy, and also some modern hybrid technologies. So if you see this abbreviation CMRI, that means conventional MRI. So conventional MRI are three sequences: T2 with high signal of the cerebrospinal fluid, T1 with low signal of the cerebrospinal fluid, and flare imaging. Or this is T1 and this is T1 with contrast. So all those conventional sequences can give us the tumor delineation, the detection. We can detect the tumor with the sequences, so we have a high sensitivity, not so a high specificity, because we can only describe the precise location, the diameter, the extension and the margins of the mass, the relation with the surrounding structures. It's very important to notice, is there any perifocal edema or not, some herniation of the brain, and some impairment of the cerebrospinal flow or hydrocephalus, and also to evaluate some vascular compromise. So we can image the morphoanatomy of the tumor and the tumor effects on the surrounding brain, again with this intratumorous structures and textures. I'm sorry. Okay, so perifocal edema, again, herniations or dissemination of the process. So what is the role of neuroradiology? Once again, we can give information about the tumor diagnosis, the location, the size, the relation with the surrounding structure. Is there any edema, necrotic or hemorrhage compartments? Are there any calcifications, cysts or herniations? Impairment of the cerebrospinal flow, hydrocephalus and vascular compromise or dissemination. The tumor grading, are we dealing with high-grade tumors or low-grade tumors? What about the extent of the tumor? How can we get the insight into tumor structure and texture? Also, we can plan treatment. How can we locate the white matter tracts by using the advanced techniques of so-called diffuser tangential imaging or tractography? How can we determine some functional cortical areas of location, or the so-called functional MRI? And also we can assess our patient after treatment, so the post-treatment assessment. Parietal lobe causing a very important edema with compression of the lateral ventricle and even displacement of the midline structures. You see that due to compression, the midline structures is depressed on the other side. After contrast injection, we can see that the tumor is enhancing very, very strongly. So it has a very important high blood supply. And this is the angiography that gives us that the vessels are displaced a little bit at the periphery of the tumor. And this tumor is meningioma grade 1. This is another tumor. Where is this tumor located? It's a small, it's a children, a young patient. And this is a tumor located in the fourth ventricle. This is ependymoma. Ependymoma are very typical for young patients. The locations are in the fourth ventricle, displacing the cerebral hemispheres, and they contain some cystic portions inside. So this is a T1 images, and this is a T2 image here. The second one is a T2. The sagittal one is a T1 with contrast. The first image is the sagittal T1 with contrast, and you see the cystic component of the tumor, of this ependymoma. An example of medulloblastoma grade 4, the same location like the previous case, the tumor is invading completely the fourth ventricle. And here are listed in this slides the major changes of the new WHO classification of the central nervous system tumors. And you can see those which are highlighted in red, which are the new changes of the classification. But if you want to use the entire classification, it's presented in these slides here. This is the WHO classification of tumors of the central nervous system. You see all the list with the codes of the different tumors. So those are diffuse astrocystic gliomas, other astrocystic tumors, ependymal tumors, other gliomas, then mixed tumors, tumor of the pineal region like pinocytoma or the other ones, embryogenical tumors, meningiomas, mesenchymal tumors, lymphomas, and so on, so on. You see the list is very, very long. So the edema, it's a very important feature, and you can see this vasogenic edema is a consequence of expansion and due to the pressure of the surrounding tissues. So if we have a patient presenting with abnormal T2 signal, which is related to infiltration of the tumor, and it could not be distinguished from this entity from vasogenic edema. And those are a few examples of edema in anaplastic oligodendroglioma, in meningioma, and in glioblastoma, which is probably the most malignant and the most worst prognosis, the glioblastoma multiforme in the brain. Sometimes in the inside of the tumor, we can observe some necrosis, which can be due to sudden vascular compromise or occlusion with predisposing factors, endothelial proliferation or thrombosis, and it has a very bad prognostic sign in high-grade gliomas. So those examples are presenting the cystic or necrotic areas inside of the tumor. Calcifications is possibly, but not obligatory, to be a slow-growing sign. So if you have calcification, that means that this lesion, this mass, or this tumor has been growing very, very slowly. But attention, it's not always like that. So you can observe calcification inside of a slow-growing, very huge meningioma, like in the center here, or some other calcifications in other tumors. But CT is the method of choice. Just remember that for calcifications. Because with MRI, you are not able to see the calcifications. They present with loss of signal, and you can see them with this susceptibility weighted imaging, which are very sensitive for hemorrhage. So the different types of cysts, they can be sequel of macular degeneration, liquefaction on transudation. They can be neoplastic and or originating from a tumorous mass. They can be also non-neoplastic or reactive if they do not enhance the contrast material. So plus CE means plus contrast enhancement, minus CE means minus contrast enhancements. So you see different histological types of tumors here. The first one is hemangioblastoma. Then you have the most worst prognosis, glioblastoma multiforme, glioblastoma, ependymoma, and pilocytic astrocytoma in smaller patients, in younger patients, and all those present with cystic degeneration of the mass. Also, it's very important with these modern sequences, advanced techniques, to rule out the intratumorous hemorrhage. If you have any pathological changes into the blood vessels of the tumors, it's rare, but sometimes it can bleed. So some tumors can bleed. Usually those are malignant tumors, but not always. So we are relying on these susceptibility weighted imaging techniques to rule out the hemorrhage. And if we observe at the periphery of the mass low signal intensity, so something very, very dark, which delineate the mass, usually these dark areas correspond to hemosiderin depositions and to some blood components, degradation of the blood components. So they are due to hemorrhage. Contrast enhancement is very important to be assessed in brain tumors, and usually we observe contrast enhancement when we have disruption of the brain-blood barrier, and when we have increased permeability. And sometimes it could be in correlation with neovascularization. So in some malignant tumors, we can have more important contrast enhancement, and usually we observe this contrast enhancement in high-grade tumors. So those are three examples of high-grade tumors. The first one is, again, glioblastoma multiforme, then medulloblastoma, and some metastases. You can see the important mass effect surrounding the metastases in the third image here. And also, another contrast-enhancing lesions you can see not only in malignant, but also in benign tumors. So pilocytic astrocytoma is grade 1, so it's not so malignant. Grade 3 and grade 4 are very malignant. Meningioma is benign tumor. The second image, meningioma with compression of the brainstem here, a little bit on the right side. And another right-sided tumor in the internal acoustic meatus, which is schwannoma. It runs from the nerves, 7th and 8th intracranial nerves, from the capsule of these nerves. It's arising from them, from the Schwann capsule of the nerves, and also some tumor-effective multiple sclerosis lesions can enhance the contrast. Some abscess can have contrast enhancements in the periphery, and some examples of radiation necrosis, which also takes the contrast of the periphery. So not only malignant tumors, but some benign tumors and benign conditions also we can observe in them some contrast enhancement. So do you think that the conventional imaging methods fulfills all the clinical questions and all the clinical needs? Not always. Is there a space for additional information with the modern advanced techniques? Yes. So if we have a few tools from God, the first tool will be the Hounsfield units. The Hounsfield units are a very powerful tool because it gives us the tissue characterization within the selected region of interest. So with only one touch of a finger, we can measure here the density in the first image in the CT. We can see that is there any contrast enhancement, is this a cystic lesion inside, and so on. But after this first tool information from Hounsfield units, we are moving to other MRI, and MRI gives us a very good tissue resolution, very good differences of the tissues, and we observe that this lesion is very cystic because it's equal in T2 with the cerebrospinal fluid, and this lesion also in T1 with contrast. This is T1 image with contrast. There is an important contrast uptake at the periphery of this lesion. And after this first tool, we have the first divine tool, which is in fact the tissue characterization. How can we characterize what is the mass in fact? So we have which and tissue, of course, tissue is the issue. As there was a very a big celebrity, a neuroradiologist from the United States, that this is his statement that tissue is the issue. What is in fact the tissue characterization? This is the issue or the clue to the diagnosis. And we have another new task in the last years, not only to make morphological assessment to say is there a tumor or not, but we should report so many other additional information. There's a lot of tasks to fulfill. So if our task is based on the CT, we should report about the flow and the perfusion of the lesion. And if we are performing an MRI, there is a huge list of tasks that we should respond: the proton density, the relaxation, the angiogenesis, the diffusion, perfusion, permeability or susceptibility, assessment of the lesion. What about the metabolic profiles? What about the MR spectroscopy or the functional MRI? And also there are few PET CT or PET MRI based tasks that we should respond. So that's why this multiparametric MRI is really very important, because it gives us not only structural but also functional or even metabolic insight into the tumor tissues. And we can here discuss about angiogenesis, about cellular density, about microstructural changes, the location of the white tracts, the motor on the speech cortex localization. What about the biochemical tissue profile, and so on and so on. So you can see different articles on the functional biomarkers and functional diffusion maps. And if we have here, this slides is demonstrating the perfusion. Why we perform perfusion? Because it provides a very valuable information about the vascularity and the angiogenesis of the tumors. If you have a high blood volume, cerebral blood volume values, that means there is a high suspicion of malignancy. So different grades from 1 to 4 are increasing with the vascularity. Perfusion-weighted imaging can be done with exogenous tracer or without exogenous tracer, and those are the abbreviation of the different imaging techniques, but you don't need to know them, all of them. One word about MR spectroscopy, which provides a non-invasively valuable information about the different biochemical features of the tissues. And we are using single voxel spectroscopy or multivoxel spectroscopy, and this can add some value to the differential diagnosis and most importantly to the tumor grading, and it's important also for biopsy targeting and for follow-up of the lesions. Why we perform diffusion-weighted imaging? Because it provides a very important information on the cellular density by measuring the random Brownian motion of the water molecules within the tissue. So we already discussed that this is a very important method in ischemic stroke, because the lesions will be very, very bright or hyper-intense in cases of ischemic stroke. And here again, we will have high tissue cellularity and parallel to the high diffusion restriction. What does it mean, diffusion tensor imaging? This is a very modern, a very new and fancy imaging, advanced imaging techniques on MRI, which gives information on the orientation and architecture of the internal tissue microstructure. That means diffusion and fractional anisotropy, shape-based diffusion tensor metrics. And this is important for surgical planning, for the surgical approach, because we want to prevent the major tracks from injuries during surgery. The functional MRI imaging relies on the so-called BOAT effect, blood oxygenation level dependent effect. And this is also important for the surgical approach planning for prevention of important speech and motor areas injuries. This is an example of glioblastoma multiforme, which is a high-grade tumor, glioma, and we see that the cerebral blood volume inside of the tumor is very, very high. The same tumor, glioblastoma multiforme, with its cystic parts, the solid part and the cystic parts, after contrast enhancement, we see the important vascular supply or the uptake of the contrast at the periphery. You are looking here on the image in the middle, on the upper lobe at the middle. So the contrast uptake at the periphery of the tumor and the two cystic components at the periphery, which in T2 imaging, the last T2 axial image, the last slice in the upper lobe, is with high signal intensity in T2. And here below we see the lower level, the corresponding MR spectroscopy image. But attention, again, high perfusion does not always indicate higher malignancy grade. Why? Because a lot of benign conditions, benign tumors like meningiomas, schwannomas, and so on, also present with high perfusion. So it's not always, the high perfusion is not always corresponds to malignant processes. Another, going back to this glioblastoma multiforme, in the parietal lobe on the right side, you see here right side, parietal lobe, a little bit displacement of the structures on the midline because there is an important mass effect with not so important, but there is some edema at the periphery. Another example for different location of glioblastoma multiforme here in the falx cerebri, a little bit slightly on the left side. And what will be the differentiation? What will be the differential diagnosis? So we should rely sometime on the ADC maps for that. But this is an example of glioblastoma multiforme because the ADC, the calculated ADC values are not so high, less than 1. So if we want to resume all these intraaxial brain masses, we are using conventional MRI techniques and advanced techniques like MR spectroscopy, diffusion weighted. Sometimes to rule out if there is any necrosis or not, we can inject contrast. Perfusion weighted imaging also is very important to differentiate between low grade and high grade neoplasms abscesses, and so on. And sometimes spectroscopy is important for the evaluation of the different metabolites. And don't panic with all those tumors. So really, it's difficult sometimes to rule out. But if we are able only to make descriptive, how to say, assessment in our report and to give one or two differentials, sometimes it's enough for you especially. And what about the indications for performing diagnostic imaging in cases of multiple sclerosis? So this is an autoimmune disease which affects young patients. And first of all, we can make MRI for initial evaluation if we have anamnestic history, and also for a baseline diagnostic imaging of multiple sclerosis. And also it's important to image the myelin, not only the brain, but in the cervical spine also, the myelin. Also, we are performing MRI for follow-up of multiple sclerosis with some clinical indications like unexpected aggravation, because you can have sometimes a remission and after that unexpected aggravation. Also for evaluation of the lesions and for therapy initiation and for suspicion of secondary diagnosis, something else apart of the multiple sclerosis. Usually annually, to perform this imaging modality annually once per year, the MRI, this is optimal. And we use contrast material mainly in the beginning when starting the therapy initiation as a baseline exam and for periodic follow-up. And let's review a few examples of multiple sclerosis lesions. So we observe in T2, this is a T2 image, and this is a post-contrast T1 image here. Increased water content, edema in acute demyelinization, also increased permeability of the blood-brain barrier, high sensitivity detection of the multiple sclerosis plaques, and the lesion. So it's important part for diagnostic, because sometimes the diagnosis of multiple sclerosis can be done not only by, it's mainly by the MRI, but also with different neurological testing, serological testing, and even with puncture of the cerebrospinal fluid in some occasions. So the most typical location of the lesions is periventricular, and they are lining at the borders of the lateral ventricles with high signal intensity on T2 and FLAIR imaging. Of course, the cerebellar hemisphere also can be affected. The brainstem can be affected here in the middle in image number B, and in number C is the most typical white matter affection close to the lateral ventricles. Here at image C, you can see affection of the body of the corpus callosum. The myelin should be also evaluated or assessed, because in up to 90% of the multiple sclerosis patients, we observe the cerebrospinal form. It's not only located into the brain, but it affects also the cerebral, the spine, the myelin in the cervical spine. In 25% it's involved in just one area, in the cervical spine only, without any affection of the thoracic and the lumbar spine. And sometimes it's multifocal, and we can observe atrophy of the myelin. So this is one lesion which is located at the level of the second cervical vertebra. So this is vertebra 1 and 2. At the lesion which is with high signal intensity, we are looking on the second and the third image. The second one is the sagittal T2, and the third one is the coronal T2. And the very first image is the T1, and we don't see the lesion in T1, but it presents with high signal intensity on T2. Moving to saying a few words about the tumors of the pituitary gland. So most pituitary tumors, they are benign tumors. We call them adenomas, and they arise from the adenohypophysis. So hypophysis has two parts, adenohypophysis and neurohypophysis. And those adenomas, they remain in the pituitary gland or surrounding tissues, and they do not spread into the other parts of the body. So you see here the pituitary adenoma. And this pituitary adenoma, after contrast injection, we always perform it in coronal plane. We inject contrast. The normal parenchyma of the pituitary gland is taking the contrast, but the tumor remains hypointense. So this rounded structure, which is hypointense, the first image is a microadenoma. And microadenoma is when the adenoma is huge, larger than 10 millimeters, and it spreads into the supracellular system. And also in this case, we are observing in the upper pole compression of the chiasma, the optic chiasma. It's compressing the very first image, where is the microadenoma. We observe just the cranial projection of the tumor. We see the chiasma opticum, which is not compressed, and in the macroadenoma it's compressed. So instead of summary, we should say what we have done and what we should report and think and observe in the patients. So and where we are going on, where we are heading to, in fact. So we are going to be micro in regard of the MR technology. So the technology is evolving very, very fast, and we have micro information on it. We are even going nano in regard of the direct visualization of the lesions. We can go ultra low in regard of the magnetic resonance imaging field with different fields of strengths of the magnets, and we are going also multiparametric in regard to the information. So we can have various type of information, not only anatomical but also functional and metabolic information. So that's why we are going multiparametric. We can also, I hope we can go one day genomic when we are able to integrate imaging techniques with future therapies. And what about after that? Where can we go further on? We don't see, and time will say us. So as Sir Arthur Clarke states that any sufficiently advanced technology is undistinguishable from magic. So with that, I will end for this presentation. Thank you for participating. And now if we have any questions, we can discuss a little bit after the lecture. Thank you again.
So, thank you, Professor.
Okay.
The only thing that I would like to